Hello. As we all are aware that AMR is one of the major challenges globally. And due to AMR, a lot of sepsis patients have a high risk of mortality. So today's discussion is on sepsis. I welcome all of you. I'm Dr. Pankaj Mandale, and with me is our expert, Dr. Neeraj Tulara, sir, from Dr. LH Hiranandani Hospital, Powai, Mumbai. Welcome, sir, and thank you to be a part.
Thank you, Dr. Pankaj.
Thank you. So as we all are aware that there's a lot of changes happening in the sepsis guidelines. Initially, it was the 6-hour bundles, then came the 3-hour bundle, then came the 1-hour bundle now. So how has these bundles really affected the treatment modality in terms of tackling the AMR concern in septic patients specifically?
See, the sepsis has given a lot of importance because everybody has realized, because this is the most common reason for death in the ICU setting. And that's the reason, the early you prevent the sepsis or early you control the sepsis, the chances of survival is very, very different. Morbidity and mortality directly depend on how you treat the sepsis.
Right.
And that's where the bundle plays a very important role. Why the bundles have made to universalize the treatment of sepsis, so we don't miss anything, we treat things appropriately, and we treat this thing scientifically. Now, earlier the bundles were made like for 6 hours bundle, then 3 hours bundle, then 1 hour's bundle. What does that mean? It means the things you need to do it in 6 hours, then things you need to do in 3 hours, and now things you need to do in 1 hour. Now, recent guidelines showing 1 hour bundle. So that shows the earlier you control the infection, earlier you follow this standard, the operating procedure, which is bundles, the chances of your survival, your patient survival, morbidity, mortality, the outcome is extremely different. So 1 hour bundles means you have to finish particular, your task within 1 hour. Right. And that's how it is important. Earlier we thought that, we will not able to finish these tasks in 6 hours. So then we made a 6 hours bundle, then we made a 3 hours, but we could see that because as the awareness is increasing, people have become very prompt and we are able to deliver all those tasks and complete all those tasks, whether it is taking the cultures, taking care of your airway breathing and circulation, taking care of your fluid challenge and the blood pressure, giving the antibiotics as soon as the cultures are taken. All those things which were earlier we were thinking it will take 3 hours, 6 hours, probably now we have made a target of 1 hour. Because the earlier we administer the antibiotic, the earlier we take the cultures, earlier we stabilize the patient, earlier we maintain the blood pressure. That's all depend on the final outcome of the sepsis and the patient.
True. Thank you so much. When we're looking at the AMR, from the AMR aspect, AMR problem which the global world is facing now, from the past 1 decade, we see a lot of resistance, especially in India, for gram-negative pathogens. The WHO has given a warning for CRE cases for A. bomni, Klebsiella, Pseudomonas, and so on, critically accurant pathogens. Also, we have a problem of NDM1s and CREs. So, how do you see a difference in the treatment modality 10 years before and at this current level? So, how challenging it is when you feel a patient of sepsis?
Yeah, that's a very good question. So, each and everyone who is working in the ICU knows that the antimicrobial resistance, the AMR, is the biggest concern and biggest threat. And sometimes we feel so helpless that we don't have any antibiotic in our kitty to deliver to the patient. Earlier we were using, if you remember 10 years ago when the NDM was discovered and it was named as a New Delhi metallo-beta-lactamase because it was first discovered in New Delhi. And it was a big news that, now the antibiotic, which was meropenem, which was the final sword, has developed resistance. So that time we were so much tense, but now if you look at the 10 years back and now, the meropenem is almost 70% resistance.
Absolutely.
Then once we started developing resistance, we tried to see that how to use this meropenem resistance. So then we, administer or we used colistines or polymyxins. And then so when the colistin was used, or the other antibiotics which were the higher end antibiotic, whether it is a tigecycline or the fosfomycin or the colistin or polymyxin B and all that, we were thinking that there was no resistance. The colistin was almost 100% sensitive. You give and the patient will recover. Now, as the Louis Pasteur itself says, the antibiotic resistance will always follow as a faithful shadow.
Absolutely.
So as we use antibiotic, we develop the resistance, and that's what has happened to the colistin. Also, we develop the resistance. Almost now 10 to 15% of the patients are even resistant to colistin and polymyxin B.
Right.
That's why the recent guidelines, if you see the 2022 IDSA guidelines, they have stress on meropenem resistance. Alternate use will be the colistin and polymyxin. Otherwise, the newer antibiotics, the newer 5th generation BLBLIs, ceftazidime, avibactam, should be used after the meropenem resistance. And if there is a threat of NDM, since the ceftazidime, avibactam does not cover NDM, so if there is a threat of ceftazidime, NDM, then the ceftazidime, avibactam should be combined with the H2N. That covers almost all the resistant bug at this point of time. Obviously, the polymyxins and colistins are also used depending on the case to case, but we do not know that how much time we are going to to continue with this also, because as we have seen the BLBLIs, all the earlier generation BLBLIs have developed great resistance now. So whether this combination will last for how long, that we cannot say that, but at present we are seeing. So we have started from the normal BLBLIs, went up to the carbapenems, then we have some the novel antibiotics with the EDTAs and all, and then we had the colistins, polymyxins, tigecyclines, the earlier all the vancomycins and all that, even for the MRSA and all that. But over a period of time, the antibiotic preference is changing. The simple reason, because the AMR is increasing every day. Right. And that's why now we have those. So last year, what antibiotic we were using with the same patient, we cannot use those antibiotics for the same patient. So antibiotics, the traveling very fast, the use of antibiotics and the change of antibiotic is happening due to the AMR.
Very true. Very true. So as from the discussion you're seeing, that the newer antibiotics are now playing a major role in your treatment armamentment. But how promising do you feel that these will help to bring down the incidence of or the treatment level of sepsis, or the faster recovery of patients with sepsis using the new armamentarium?
So at present, the new antibiotics which are there, they are able to bring down the infection. They are able to control the sepsis, but the threat is the AMR. That's why today we are talking, and that's what the world is talking, that we need to reduce the AMR, because we do not have enough antibiotics in pipeline, and we know that these antibiotics which we are using, they will be of no use in some time. So if we need to preserve or we need to save the future, then we need to reduce this AMR.
Right.
That's very, very important. If we able to reduce this AMR, that's the only thing that probably that we will able to use these antibiotics which is there today, maybe for a few more years. Otherwise, the same thing will happen which happened to the meropenem, which happened to the colistin, which happened to the tigecycline, which happened to the other antibiotics which were there earlier. And now this will happen to the same fate will happen to the current antibiotics also. So at present, they are able to manage the show, but maybe it will be just past if we do not use antibiotic judiciously, if we do not follow the antibiotic stewardship program. So that's very, very important, and all efforts has been made from all the societies of the world which are concerned about the infection to reduce the AMR, because if we able to control this AMR, then only we will able to use these antibiotics for a longer period of time.
Absolutely right. Absolutely right. So as we move ahead from the sepsis, so are there any guidelines, or are there any pattern of treatment for post-sepsis treatment for patients that we have to take into consideration, so that the patient recovery after sepsis recovers pretty fast?
So, the post-sepsis treatment, the main part depend upon what we do during sepsis. So how you treat the patient, because many of the time we see that the patient's infection recovered, he come out of the sepsis, but he'll end up with the other problems, the side problems, the comorbidities and other things, they get resurfaced. And then in the post-sepsis, you need to manage all those, the complications which happens during the sepsis. So while, the maintaining the sepsis control, also we need to look at simultaneously and collaterally to keep looking at all the organs and all the comorbidities, because we have seen, now the recent example during the pandemic, we have seen the COVID. Yeah. During the COVID, though we have managed the COVID beautifully, but we have seen the post-COVID complications, like the patients have become frank diabetic. We had seen a lot of opportunistic infection like the mucormycosis and other type of infections which were not prevalent earlier. So ultimately how you manage the sepsis, the outcome depend even in your post sepsis management. So if sepsis, as we said, that if we treat the sepsis properly with the good antibiotic and the following all the bundles, probably we will come out of the sepsis. But during the sepsis also we need to control the your kidney, your lungs, and your the sugars and blood pressure and all that, because we have seen the post sepsis, after that the antibiotics are over, but maybe the sugar will continue to be on higher side. Patient's heart has got the damaged, he needs some medicines for the heart. His lungs are damaged, he develops some sort of fibrosis or other problems for which he continue to need some sort of treatment for support of the all other organs, because sometimes the sepsis can be as prolonged as a few months. And the patients come out of the sepsis but land up with the post sepsis complications, critical care neuropathy, lot of post sepsis complications. So management of post sepsis complications is very important, and it all depends upon how beautifully you maintain the treatment during the sepsis. Post sepsis management is mainly a supportive, okay, because you have already tied over the crisis. Now you have to just maintain all the parameters, all the organs in a harmony phase. Right. So for that, you need to just continue to be supportive treatment, not to be very aggressive, whether it is some sort of, the nutritional programs, whether it is some sort of rehabilitative programs, whether it is some sort of, the emotional programs, mental programs, because there is a lot of mental issues, a lot of emotional issues, a lot of physical disabilities after the sepsis. So post sepsis, these all aspects we need to manage, and we need to manage in such a way that patients, they come back and recover completely to a before sepsis stage.
Very true, very true. So from the community aspect, what would be the suggestion as a clinician, the post-sepsis precautions the patient should take when he or she recovers from such an incidence of sepsis?
So once the sepsis, we need to know that a sepsis is a very huge immunosuppressive stage. Like we know that cancer is an immunosuppressive state, the HIV is an immunosuppressive agent, the patients who are taking steroids, they are immunosuppressed, but sepsis also makes your body, your immunity down to a very, very weak level or the low level. So once you recover from the sepsis, you always have a chance to develop few other infections, opportunistic infections, or other infection which is not the other person will get it. A normal healthy person will not go to get those infections, while a person who is recovering from the sepsis, coming out from that immunosuppressed stage, is prone to develop those infections. So once you recover from the sepsis, you need to have a good nutrition so that your immunity continue to be on a better level. You need to continue to monitor your vital parameters. You need to continue to maintain all the comorbid conditions and control them, like whether it is diabetes, whether it is hypertension, whether it is cardiac failure, heart failure, respiratory failure, or whatever. So you need to keep all the organs in a healthy condition. Not only the infection which has already been managed, but all the organs need to be managed in a healthy condition, in a controlled condition. Then only over a period of time, we will recover completely. You may be out of the ICU, maybe in the ward. That's how it happens in the ward. You will start to be mobilized. Your sugars need to be controlled. Your pressure need to be controlled. Your mental status need to be checked, because post sepsis psychosis is a very big term where the people, have a big psychotic stage. So all these aspects has to be managed after coming out from the sepsis. And that itself will take a lot of time to heal. So you come out of the ICU very fast, maybe 5, 7, 10, 15 days, but maybe coming out to a normal stage may need a long time. And those aspects, because most of the time what happens, we probably all push for the sepsis, we control the sepsis, then we leave the patient. And then patient will end up with a nutritional problem, mental problem, or some sort of rehabilitative problem. He's not able to mobilize. Then he'll come back with a bad source. His sugars are uncontrolled. He'll come back with a diabetic ketoacidosis. So those complications, which is actually not there, but those were not managed in the post sepsis phase. So those were all important part of the full program as a holistic program.
Fantastic. $1 million questions at last. What are your expectations from the pharma research and development organizations in terms of antibiotic development or the support for the antibiotics which the clinicians get? Because you have been working at the ground level, you know what the concerns are. What do you feel you wish to have the support from the R&D, pharma R&D?
See, as far as we know that there are not much antibiotics are in pipeline. Pharma companies are doing R&D and trying to get new and new antibiotics, but as all are aware, it's a huge, costly process and it takes long time. And as we have already discussed, that the antibiotic develops resistance so fast, then the people may not, the pharma companies don't give so much of importance for the antibiotic as compared to the metabolic, the sector. Here, so what we expect from the pharma companies that one, you need to, the people who are manufacturing or selling the high-end antibiotics, they need to concentrate mainly on the antimicrobial resistance. Need to make sure that the misuse does not happen.
Right.
So one particular molecule, suppose what we are talking about, that which is used today, if it start getting available to each and every one counter, and each and every the hospital or doctor start using, then that's where the problem starts.
Absolutely.
Then the misuse becomes a big problem, and then you will soon develop a resistance. So the antibiotics, which is a very high-end antibiotics, need to be used as a last resort, should be only and only prescribed by few doctors which understand the importance of those medicines. Should not be prescribed by any doctor or any hospital or any nursing homes where these can be used. So it should be made available only in particular hospitals where these type of patients are there. So that's what the pharma companies need to, the focus that this. So in fact, it's a win-win situation to even for them as well. If the antibiotic remain sensitive for a longer period of time, you will continue to sell the antibiotic for a longer period of time. But if it become resistant, then we ourselves will stop using. And when we are not using the antibiotics of no use, whatever the the cost has been spent on the R&D and other procedures. So we need to focus that this resistance does not develop. That should be the main concern. The AMR should be the main priority, not only for the doctors, not only for the hospitals, even for the pharma sector. So hospitals, they do it as an infection control program. Hospitals are also following, most of the hospitals which are corporate governed with the the government guidelines, they are following the antibiotic stewardship programs. Same way, the pharma also has to, judiciously, they should make the people aware more and more, because those are the pharma guys are the main people who are meeting each and every doctor. So they should make aware them, sir, you need to use these antibiotic at this particular indication, not to just to promote and just to increase the uses of the antibiotic. As I said, in long run, it may be even the loss to the company itself. So it's a loss to the company, loss to the mankind, and loss to the antibiotic also. So for that, we always need to focus the main concern for the high-end antibiotic. The development is not much. The kitty is very small, while the usage is big. So we need to judiciously use where we can use these particular antibiotics and where we can spare those antibiotics. So that's how we need to decide, and that we need support of each and everyone, all the stakeholders which comes in this category. That's the time probably we will able to stop this AMR, or at least control the AMR. Fantastic. And where we can give a better outcome to our patients who probably some people are dying because of the unavailability or the extremely drug resistant bacteria where no antibiotics are sensitive. So that seems to be very, very the pity situation when you are seeing those patients, and become very dangerous for the patients who have these infections.
Very true, very true. Thank you so much, sir. With me is Dr. Neeraj Tulara, sir, from Dr. L.H. Hiranandani Hospital. He's a physician and infectious disease consultant from Mumbai. Thank you so much, and I'm definitely confident that this discussion will be very fruitful and will be very helpful to all the clinicians as well as the community people who will be watching it.
Thank you, Pankaj. Thank you, everyone.
Thank you.
Issued in public interest by Plea Charitable Trust, an initiative of Venus Remedies Limited.